I'd like to welcome you to another one of our ongoing series entitled The Power of Pivoting, Managing Through Crisis, the HSS Response to the COVID-19 Pandemic. I am C. Ronald McKenzie, an internist and rheumatologist at the Hospital for Special Surgery, and I serve as the moderator for this series. Now, while it's obvious to the entire U.S. population, indeed the world, that the COVID-19 epidemic has put unprecedented stresses on the healthcare system, unless you had a family member severely ill with this condition, one of the underappreciated consequences of the pandemic was its impact on family communication. Now, how this challenge was uniquely addressed at the Hospital for Special Surgery is our topic for discussion today. And for this purpose, I've asked the two leaders of that effort to come and discuss their response to this issue at our institution. So I'd like to introduce Mandip S. Kalsi, who is a board-certified anesthesiologist at the Hospital for Special Surgery, and Mary F. Chisholm, also an attending anesthesiologist at Special Surgery and one with both palliative care and regional anesthesia experience. So welcome, Mandip and Mary. So maybe you could tell us a little bit about what you had observed as you began to look after these patients with respect to the need to augment the communication between the healthcare providers and the patient's family.
I'll take that question, Ron, and thank you for giving us the opportunity to talk a little bit more about our experience, sort of thinking about and creating this team during the pandemic. I think this effort came out of a conversation that Mandip and I had on the first day that HSS began receiving intubated patients with the COVID illness from our sister hospital, New York Hospital. And it had already been a few weeks, and as you said in your introduction, we were aware of several things related to COVID and to the pandemic here in New York City. This was a new illness. There was an escalation of patients coming to emergency rooms throughout the city. These patients could become ill acutely and decompensate very rapidly, leading to intubation and requiring long-term hospitalization. And even though the incidence of death in the population was at the time around, we thought about 3%, that incident was much higher in the hospitalized population. So. And because of the illness and because it was so highly contagious, these patients had to be immediately isolated and removed from their families. And I think that so when we got together, I was exposed to what was happening through my experience with the bioethics team at New York Hospital. As a result, I knew things that were going on there. I was privileged to hear about interactions that were happening through the leadership there. And Mandip, and I think he could talk a little bit about, from his point of view, he was seeing what things were happening in his role with the resuscitation committee and in his support role to the intensivists.
So just to add to what Mary has already shared with us, while she was over at NYP working with the bioethics committee, a number of us, myself in particular with the HSS Resuscitation Committee, were trying to figure out how do we need to update our protocols for dealing with COVID positive patients. What do we have to do for our intubation procedures? How do we want to respond in code situations? Kind of very clinically oriented protocols in terms of PPE and what techniques we want to use, who wants to go into the room. And one of the things that became pretty clear is that the previous, the typical HSS patient is a full code. They're coming to this hospital for an elective procedure and have every intention to leave this hospital in full capacity and continue on with their lives. With the patients that we were now, anticipating seeing, this would be a different conversation. And so part of why I sought Dr. Chisholm out is because I knew that she was already having to deal with these issues with NYP, and so that I think was one of the reasons why we ended up having that conversation. We at HSS, I don't even know we had any DNR bans in the hospital. So just to even, just to say kind of how far we were from having those conversations, can't be overstated.
So can you tell us a little bit about the structure of this communication team? Who were the participants? What were their expectations? How were they chosen? I was one of the team members, so I can perhaps add a commentary to that at the end.
I think that in terms of this need, so we saw that patients were isolated. Intensivists were extremely stressed in terms of being overwhelmed with patients. There was a need to have these kinds of conversations with family members. We felt that we needed to have physicians, people who were medically literate, who could read a medical chart and be able to interpret that medical chart with the help of notes that were placed by the intensivists on a daily basis, so they could stay updated on the status of that patient and be able to translate that information to a family member. So that was one thing that we were looking for in this communicator. We also wanted someone who would be able to help with the service liaison team, which was already in place, to help with these communication between the family and the intensivist team, to identify the appropriate decision maker in case we needed to have goals of care types of discussions, and began to talk about a need to change someone's status, really, in terms of going from a full code to making that patient DNR. So that was another aspect to what we were going to need from this individual. The third thing would be that in addition to medical literacy, this need to help identify the appropriate decision maker, we wanted somebody with sort of the ability, the bedside manner, the clinical skills to really establish that ongoing relationship with the family, to help them in terms of emotional support and to develop that resilience they were going to need to see this situation through. Mandip, did you want to elaborate on that?
So yeah, I think that's very true. I think the other thing to appreciate here is that traditionally it was the ICU physician that was having these conversations with patient family, and so much was unknown going into this. We did not know how many patients we were going to have in the hospital. Were we just going to have the 16 patients on the 9th floor? Would we have the entire PACU? Would there be 30 of these patients? Would we have to convert the ORs on the 4th floor as well? So a lot of this was created in anticipation for something that we knew we couldn't completely know what was the total capacity of that was going to be. And we knew that even just if we had the 16 patients on the 9th floor, to have a 20-minute conversation with each of those patients would be, almost 8 hours of phone time. And that was going to be very, almost impossible for our ICU physicians to do. And so another kind of purpose of this was just to create support for both the ICU physicians and then also create support for the families who would definitely need that support in this situation, which we really didn't know how severe it was going to become.
From my experience in participating, I could see that you chose very senior clinicians, both from the Department of Anesthesiology and I think medicine, perhaps other domains, to perform this function. Can you tell us a little bit about that decision-making process?
Sure, I can respond to that. I think that we had physicians that, for one reason or another, were not at the hospital, and these were excellent clinicians, They had true commitment and willingness to help. They wanted to be involved, and so they were ideal for this role. And I think also we intentionally did not choose people who were involved in the front lines because, frankly, because we knew that people were putting themselves at risk and were being exposed to the virus. And so we wanted to use people who would be able to commit themselves to these relationships. And we made it clear from the very beginning that this was a commitment that would mean daily communication for as long as that patient was hospitalized at the hospital for special surgery.
So, I can comment, as I say, as a team member, that I thought from the standpoint of its organization, it was a remarkable effort. And remarkable in the sense that it was up and running so quickly and so efficiently. And I had tremendous support from the patient services communicators who would have usually talked to the family member before I made my call. I would be prepared with what the family had expressed as concerns over the preceding 24 hours. I would have an opportunity to access the medical record and bring myself up to date. I got daily reports from Dr. Urban, who was a sort of central repository of information to the team members about the status of the patient. And frankly, when it really came down to instances where very vital decisions were to be made, such as whether or not a patient would be resuscitated, if they were in circumstances that would require that, or possibly be extubated or have the endotracheal tube removed, I had access to personal conversations I could have with the ICU staff or the palliative care staff. It really worked tremendously well and consistently so. And I can tell you that the families were extremely grateful for it. And I think, several of them had come from other institutions where they really felt lost in terms of the communication. And I think we're really very, very grateful for these efforts. And maybe Mandip and Mary can comment on that, but I think that they both should be tremendously congratulated for coming up with this idea and then pulling it off so beautifully.
I really feel that it's a tribute not just to us, but to HSS and to the people that we work with. We had the idea, but in preparing for this, I went through our emails and then we discussed it, the history of this. We talked about this on the first day that patients were transferred, April 1st. That night, Mandip sent an email to our director, Dr. Liguori. By 7:30 the next morning, he had responded saying, let's get this together today. By the end of that day, Bobby Stack, who's the assistant vice president of our department, Greg Glagori, Dr. Mayman from surgery, Bella Ellagooden from the service excellence team, and had pulled together, and they in turn pulled together other support staff for IT, and Mary Kelly, who was also who's the director of our perioperative pain services. All of these people work together in an extraordinary fashion that I consider myself privileged to be a part of it. It was a tribute to the teamwork that I feel is a part of the way that is a part of HSS, really.
Yeah, and I'll just add a point afterwards. It's also it's building upon the culture of HSS already. I mean, the service liaison team exists. The understanding that we need to do everything we can to not only provide our best patient care, but communicate that to patients and patients' families, I think is very it is the HSS way. And everybody involved, all those people involved, appreciated that. I mean, even we can just say how quickly we were able to get a dedicated note section in Epic just for this team to do that, when normally it takes months and months and months to get anything changed in Epic. I think everyone here understood how necessary this was, and is deserves tremendous credit for putting this together. It was a tremendous team effort, and to see it go from an idea on Wednesday to a fully formed program by Friday morning is beyond impressive. The other thing I just wanted to add to Ron, your previous kind of comment before, is this really did help the clinical team. I was one of the anesthesiologists on the ninth floor who was supporting the ICU physicians as they were taking care of patients. This early stage was very challenging for everybody involved. Not only is it just taking care of these patients, but turning 9 ambulatory operating rooms into, or 8 ambulatory operating rooms into, ICUs is a tremendous endeavor that nursing was involved with, respiratory therapy was involved with. You had scrub techs and you had nurses from the floor that were doing things well beyond their scope. To take this responsibility from them and to give it to this team was tremendous in allowing them to develop and grow that clinical practice while not having to worry as much about this. The other thing that's really important is that this person, and you, Ron, you might be able to speak to this, stayed with this family throughout their stay. So even as the ICU team changes, even as the clinical care providers change, there wasn't the same need to have a new conversation with a new person. You were able to develop that relationship. I'm curious to know your thoughts on that and how that experience was for you. I think that's a really, really important thing to realize, that this team really did support everybody involved, clinicians on the ICU, in the ICU, and the families, and that's really an amazingly beautiful thing.
I think I can make a comment about that, Mandip. So, you did quickly become very engaged with these family members, and they became really quite dependent on one as the source of information and actually some comfort to them. You were obviously a constancy because the ICU staff, as you point out, did change, sometimes on a daily basis. And you soon realized you were the person who actually had perhaps the broadest perspective or 20,000-foot view on what was actually happening to the patient. And I can tell you that the hardest part about it was, the audience may not appreciate that this function existed as long as the patient was in the intensive care unit. So there were only a number of ways that they exited that arrangement. One is that they were extubated and they could be moved to a floor, which in one case for me happened, or they expired, sadly. And so there was a point in the process with every one of these patients that we had to exit from that arrangement and hand it off to a more traditional person, which would be the physician on the hospital floor, let's say, interacting with the patient. That was a very difficult moment. It was difficult for us as team members, and it was very unsettling and difficult for the families. I think they were really disappointed that this interaction had to come to a close, and it probably was the most awkward point in the whole process, as just an observation from a team member. And you could do what you could to kind of cushion that and help with the transition. And generally, families were very accepting of it, not happy about having lost this voice and this focal point of communication, but they understood. And we're very, very grateful, I think, for the whole program.
Yeah, I think that probably it has to speak to how important you were to the family members for this process, and how valuable you were, that they would have liked, and maybe, there would have been, maybe we should have considered that as well, going forward, is that because it's not as if these family members can now visit their patient, their loved ones, or the medical physician on the floor doesn't also have a tremendous workload. So I think this is something to consider for the future, and maybe something that we need to evaluate if this ever has to happen again.
Yeah, if the patient was transferred to the floor at special surgery, it was relatively smooth. So you could talk to the doctor who is identified, and which is what I did, and more or less make a handoff that had some content and meaning to it. The other example, which just really happened for me yesterday, was the patient was transferred back to the New York hospital. That's a really different matter. That was really not possible to make the transition anything more than what it was, which was relatively abrupt.
Yeah, it's interesting because this is something that certainly Mary Kelly and I talked a lot about as it happened, because Ron, you're describing your experience, and obviously this happened for just about every member on the team. And I think that it does speak to the fact that you were really a touchstone of humanity in a time when because of the nature of this illness, people are so cut off from their ability to be at the bedside, to touch their loved ones, to participate in the process. So I think it really does speak to that. But I guess we had made a decision about the team about it being the prudent decision to end the role at that point, rather than sort of try to the difficulty of continuing it beyond that. Though we did leave it open through the service excellence teams to that the family could call in and could request a conversation if they really wanted to do that, if they wanted to pursue that. So it does speak to how challenging the time is, though. It really does.
Well, I bring that up not so much of it as a problem as, in a sense, an index of the program's success. And Mary, I think you do make a very important point, and that is to emphasize the role of the patient services coordinators, who were extremely thoughtful and engaged individuals as well. I think they probably felt, just as I did and the rest of us did, this termination of the role as somewhat difficult.
Yeah, and I think that, yeah, exactly. But on the other hand, I know that the teamwork and the collaboration between the communicator and the liaison was also, I think, was also very important and unique.
Oh yeah, absolutely. It was really, I felt sort of vital to any capacity that I had to be successful in this endeavor.
Yeah.
So I think we could maybe bring this to a conclusion. Is there any plan to follow up with families at some later point in time, either to bring some closure to the interaction, or even to get some sense of their reactions to the importance of the work of the communication team?
It hadn't occurred to us, but that's a great suggestion, and I think we should do that.
I will add one thing. I think that what's come out of this is, there's been kind of early discussion and planning of Mary Kelly had this idea of some sort of bereavement program. And so I think you spoke to this kind of abrupt termination of this relationship you have with his family that doesn't necessarily need to be that. So I think we're in the early stages of developing some sort of bereavement program, some sort of support system for those family members. That's one of the things that I think is on the horizon. How far along that is, I don't know, but I think that's something that's come from this. Mary and I have talked a bit about kind of how do we just even trying to understand the true scope of this program, and I think trying to get a sense of how the physician members felt, how the families felt is an important part of truly understanding the effect of this program.
Yeah, I think that would be a great idea. The other thing I might make as a suggestion is if the patient services coordinator could keep in touch with these families. In my instance, both are probably not going to end happily. And although they're both still alive, and if that is the case, I personally would like to have one last opportunity after it's concluded to call and speak to the family and sort of sign off in a different kind of way.
Mm-hmm.
Interesting. I think that's a very good point.
Well, listen, Mary, Mandip, this has been a wonderful effort on your part, highly successful, extremely deeply thoughtful and responsive to the needs of the community. I suspect quite unique. I'm not sure this exists anywhere else, and I think it's something you just should be so proud of, what you've achieved here, and know that it was as meaningful an experience as a participant in it as it must have been as a creator. So thank you both very much for this, and thank you for coming and sharing your thoughts and observations about this important effort.
Thanks for having us, Ron.
Thank you.